the interesting thing is when we look at the payer mix for both New York State and Massachusetts, the payer mix is much more favorable towards commercial patients. And why is that? That's because Massachusetts Medicaid and New York Medicaid don't want their Medicaid patients crossing the border. Okay, in Massachusetts in particular, they have an ACO in Berkshire County, and those patients, unless it's emergent care, have to stay in Berkshire County or Massachusetts. So, and we continue to work on that. We are to a good to half of Berkshire County, we're the closest hospital. So we have challenges with that. And in New York, it's the same thing. New York, this is my second hospital working, on the border of New York State, and New York Medicaid is clear. Stay inside of New York State if you can. So that's what drives, when you look at the payer mix from out of state, it's much more favorable. That's because we have a lower Medicaid. And when you start using percentages, you have to be careful. But that is clear.
Okay.
So we can, if there's a need, we can go through and look at this data more closely. But we've been tracking this for almost as long as I've been in SVMC, based upon cash collections, inpatient, outpatient, and we saw an increase many years ago from Massachusetts when a local hospital closed, a small regional hospital, and we've seen an increasing. The other thing that we look at is our inpatient, outpatient, and physician practice mix. And when you look at our hospital, we are a much different hospital than when I arrived 12, 13 years ago. We were about 30% inpatient volume. From a cash collections perspective, let's call it 2010. We are now 81% of our business, and that's cash collections, is from the outpatient or physician practice. So you can see the change in the organization. And I think that's a credit to our physicians. And I think some of the things we're talking about, improving access, we may see some increases in outpatient, but as we get more services, we'll then see some increase in inpatient, and it'll all get smashed together, and our percentages may change slightly.
Okay, thank you. Always happy to get better feedback on our blind spots, so we can take that offline. But if the board has any other questions related to utilization, we'll ask those now, please.
I have a couple, but I'm not sure if others want to go first. Chair Foster, what's your pleasure?
No, go ahead.
Okay.
Please.
Great, thank you. So thank you all. Your presentations are always really helpful, and this utilization question is one that Director Lindberg mentioned already, but I just want to probe a little bit deeper into this idea that you're trying to reduce some of the outmigration. You're increasing your scope of services. You're adding cardio. You're adding ortho capacity, surgery capacity, and you're keeping your inpatient assumption flat and your ED assumption flat, even though you're expanding access to primary care. So I guess my first question is, did you do any type of sensitivity analysis on these utilization assumptions, modeling ranges of, likely ranges of inpatient and ED as you're trying to increase access and increase scope, just to get a ballpark figure of what NPR could potentially look like if your assumptions here are off?
So, Jessica, one of the things that I was really, I wanted to be cautious of is I didn't want to over project, because, as we start increasing these services, they're not going to start overnight. Okay. And so I didn't want to over project those. And then improving access also should decrease, hopefully, our ED visits and our admissions as we get people into the practices. And as Trey said, we see them, we can prevent. So we need to get some better data. Okay. And we had a study done over a year ago that working with Dartmouth when we were evaluating affiliation with an outside firm that shows that there is opportunity for us, but we don't have those services and those things in place yet. The one place that we do have probably some opportunity sooner is in oncology. As we saw in the narrative, that we're going to be fully staffed in oncology. We're going to have 2 physicians and 1 associate provider. We haven't had that since way before the pandemic. Okay, so we will probably pull some of that outpatient back, and then there may be some surgeries and some other inpatient services. But it takes time, and the study that we did with Dartmouth shows it out in 25, 26, and 27. So, and we have some projections that and we're going to be refining them after this whole budget presentation, and time when we submit some CONs related to our adolescent psych, that you'll probably see some of that. But we still we need to be cautious for 24 because things are just at its infancy. And I didn't want to overshoot or undershoot.
Okay, so I totally understand that there's a lot of moving parts here, and predicting utilization is always a challenge, but certainly when you're adding different services and trying to do increasing access in primary care while at the same time adding more surgical and other specialty capacity, the net effect is hard to predict. I understand that. Yes. So let me ask you this then. If your utilization assumptions turn out to be underestimates, particularly on the inpatient side, would SVMC consider a mid-year downward adjustment in commercial rate? In other words, to keep the NPR whole, if your utilization turns out to be higher than you anticipated, that would keep the budget whole, but give commercial ratepayers some relief. Is that something that's in your consideration for this year?
We've always, Tom and I have always discussed as we start going through the year, the impact on that, on the commercial rate. A couple years ago, we were a little behind, and we were thinking about coming in. We discussed it. We modeled some things, and it came in. So we're constantly, at least the past years, constantly looking at. We got a rate increase of X. Okay, what's happening? Okay, one of the things that has happened in the past, just using the past as an example, Jessica, is that we have seen also a greater increase in our Medicare patients, which takes away from the NPR as Sarah distributed. But we always evaluate what we got, what we need, where we are, and what we think is going to happen in the future. And I think 24 and the beginning of 25, there's going to be a lot of moving parts. So we're always evaluating it.
Got it. All right. And actually, this is just related to the utilization. This has to do with the avoidable utilization. And Dr. Dobson, I completely appreciate your concerns about how do you measure it appropriately. There are certainly people that come in that it might appear as if it's an avoidable visit, but in fact it wasn't. But as I look at this, emergency department utilization, 11% of the ED admits were admitted. Does that seem like a high number, low number? Is that a number that you would target? Is that a proxy for anything related to avoidable utilization, avoidable visits? As you look at that chart,
we typically, and Jessica, I can't quote where this comes from, but you look at rural versus inner city, and then you look at academic versus community hospitals. So 15%, 16% is what it was when I started here, and we want to keep it, around that, and slightly less would be would be good. For an academic center, inner city hospital, you know, those numbers are in the 30s, 35%. But that's not the situation we have here. And unfortunately, you know, some of that doesn't include some of the transfer situations we have where patients get transferred to tertiary care. And that is actually slightly increased. And as we go through the numbers, just to head off another question, why did it increase? And it's not just this year. It actually increased for variable reasons. One is standards of care. So multi-organ trauma no longer stays at a community hospital. It hasn't for about 5 to 10 years. The literature supports it needs to be at an academic center. Minor heart attacks, which I mentioned earlier, there was a big push in the mid 2000s that those all need to go to academic centers or cath capable centers. We're hoping that seems to be a waste, and I think that the literature is turning that around. But back to your question, you know, 11 to 15% seems to be a number where we feel certain that the patients that are coming in, first off, need to be there, and that the patients that come to the emergency department likely needed an emergency department visit. You know, our urgent care is so close, patients can self-select. And during the pandemic, we actually were able to select for them, which we cannot do anymore, of course.
Great. Okay. Well, thank you. I'll let others ask questions about utilization. I won't take up too much time, but thank you for that.
I'll just hop in. One of the questions that I had in follow-up to the migration discussion and the reducing out of migration, I didn't get this from your narrative, but from the discussion today, it sounds like a lot of that focus is connected to the DH affiliation. So am I getting that right? So the idea is right now you're transferring folks to Albany or to another hospital, and what you're hoping is that with the DH affiliation, you'll be able to keep more folks in-house. Is that really, when you're talking in your narrative about the reducing the out migration, is that really the bulk of it, or what am I missing?
Tom, you want to take that?
Yeah, Robin, Albany will continue to be our major source of where we refer patients for. I mean, the proximity is much closer than DH. I think we're going to see more and more of elective work over time going to Dartmouth for admission. But I would continue to say that Albany will be the majority of that. You know, I think the more we can keep locally, again, as the numbers that Sarah showed, the costs outside of SVMC are substantially higher. And we think with the services that Dartmouth helps us create here with their support, we can, you know, that out-migration number, and the number is old, but I think the number was about $50 million of care leaves our region, leaves our area per year. We think that, you know, certainly a portion of that, maybe, you know, up to maybe over time, 1/3 could stay locally here, and it could be treated at a lower cost. So, but the strategy with Dartmouth is to provide as much care locally, and hopefully we don't have to, you know, send as patients out, and also send up to Dartmouth. And they really want to have the quaternary care, tertiary care patients. They don't want to have lower level patients, and we want to keep the lower level patients here in terms of the acuity. So that's kind of the strategy.
Yeah, and Robin, simply also, if we improve access, and patients that live in our service area that currently have a primary care patient physician outside of our service area, if they can get into our practices, they probably will use our services more. So, that's all tied together. Kathy?
Yeah, the one already apparent example we've referenced is oncology. We have many patients who had to go outside because they couldn't get appointments for their treatments. They've gone to New York or Boston or Dartmouth, and now they can get those services there. And it's a huge deal. I cannot tell you how many. Obviously, cancer is very prevalent. So many people have been so disheartened by the need to go outside because they couldn't get appointments, and now they can. So that's a very big deal.
Yeah, to follow up on Kathy, it's, unfortunately, we've had 2 people in the finance department diagnosed with cancer that couldn't get in to see our doctors, and they had to receive treatment outside of their where they work. So now being staffed up, we'll be able to they'll be able to receive their treatment in the future at our facility.
Thank you.
Robin,
The other,
can I
oh,
just-
yeah, go ahead. Yeah, of course,
I'm just
Trey.
sorry, I'm gonna jump in real quick. Granular
Yeah.
answer to your question. I'll just use oncology since Kathy gave the beautiful example. You asked about DH. So first off, back to your original question, we're talking mostly about outpatient here, not inpatient. That's to answer that first thing. Then the second is, if we'll go with oncology, what we're saying is without that relationship with DH, our ability to be fully staffed is really not there anymore. Oncologists do not want to practice in a 1 and 2 practice anymore. They want to be in a larger practice where they can continue to do academic research and they have the support, and that's unfortunately due to specialization. They're even further specialized. So an example of this is in the past, first off, we can recruit more. Now, in the past, someone may need a particular type of chemotherapy for a short duration for a complicated cancer. They would go elsewhere and they would stay elsewhere. They wouldn't come back here because what would be the motivation from that other place to send them back? We now already have patients that we do 90% of it. They need to go up for 1 or 2 special things. But then they just get referred right back here and into the system where they belong. Head and neck is a great example. They used to all go elsewhere. Now head and neck cancers can stay here for the most part. They may need to get a little bit of debulking procedure at DHMC, and then they return.
Thank you. And then just one more quick, what I hope will be a quick one is, Steve, you mentioned increased insurance denials. Could you give us a sense of, is that self-insured, MA plans, just any trends you've seen in terms of where that's coming from? Or is it just across the board?
I would classify it across the board. United Healthcare has been difficult, but we don't have that much volume. But when you look at the proportion of what we're seeing, and I think the real answer is across the board.
Thank you. I think that's all I have. Thanks.
Thank you. Other board questions? Dr. Merman.
I just, thanks for the presentation so far. I haven't had a chance to comment or question. Actually, I think I might venture just a quick comment, which is, Dr. Dobson and I are both emergency physicians, and we think about the admissions numbers, and over time, this has been used a lot through research as a marker of acuity, but it also seems to be a marker of bed availability. I don't think these numbers include transfers. And there's also an argument that a low admissions number is an incredible amount of work that the emergency provider team has done to try to come up with a solution other than admitting the patient. So it's kind of a complicated number that speaks to a lot of things, but I think it's an interesting number to view over time. But I think it's a very multifactorial, heterogeneous group. The questions I was going to ask the 2 of you, or the 4 of you, is when you were talking about utilization, one thing that's come up in the primary care advisory group and in other situations is other information that we get is on available visits in a primary care provider's schedule for urgent visits, and sort of the complexities of trying to fill a schedule to make sure they get their visit numbers versus having availability so that you can get urgent visits in so that they're not having to go to an urgent care or an emergency department, but can be seen by a person who knows them. How do you approach open slots for PCP visits for urgent visits?
Trey, you want to take that?
Sure. Well, I can say, not great. We've been working at it really hard, and that's what we've been doing over the past, many years. But the last year, we've started to make some headroads. Really, when I say the last year, this year, January on, and it's by using data that we've verified and we know to be right on an individual's, the primary care physician or provider's schedule, so we can actually say, do we block off additional time here, or do we just double book and then not double book in certain times? So right now we're sort of in an experimental phase, Dave, where we've looked at which practice is doing it the best, which practice out of our 6 actual primary care, including peds, has the most availability in slots, and so we're mirroring that. and I can tell you in about a couple of months how it's going. Right now, it looks like that's part of the 5% increase we've seen over the past 3 months is by getting urgent visits in. They do send people to our own urgent care, which is better than some other urgent care because at least it's, you know, they know each other and it's in the same computer system, but it's certainly, as you point out, not near as ideal as getting them into their own practice. So some practices have availability in the morning or afternoon, extra slots. That sounds great. It might not be the best approach. It may be a better approach to lighten up the double booking and go with that. So I'll let you know. Lots of work on it though.
Yeah, I guess thank you for the attention to the problem, and I wouldn't venture to think that I could understand how to solve it, but I really appreciate your discussion of it and your attention to it. The other question I had for you, you mentioned in your narrative some local independent primary care providers retiring, some people leaving practice, and I was just wanted to see if I could get an idea of what the landscape is for independent providers in your area, if there are independent primary care providers or if there are any independent specialty providers in your area, and if they work with Southwest on, you know, admission privileges or those sorts of things.
Right. Yeah. So they just continue to dwindle. I would say that we now have about less than 4 FTEs of independent primary care, maybe 5 FTEs. When I say that, because some of them are part-time, left in the area, and that's compared to probably 15 when I started. One of those is the FQHC that is it's in our health service area, but it's in Arlington, and that makes up the bulk. The rest are, you know, 0.5 practices where people are retiring in 2023 and 2024. And one just sort of prematurely retired, unfortunately, due to some health reasons this month. So as far as specialty, it's the same. It's very few. We have some oral maxillofacial surgery, which will probably continue to be private for, you know, many more years to, in the entire state. I think most of them are, except probably around UVM. And then ophthalmology continues to be independent practices. Of course, they're on medical staff. Everyone's very close. Most people don't know the difference from that standpoint. It is part of the reason, though, that we need to get this new practice off the ground pretty quickly, where we're training advanced practice providers, and then, of course, the residency program over time.
Okay, thanks for that detail.
Any other questions from the board?
I just have a follow-up from Member Holmes's question on the potential to come with a rate reduction. I wasn't really sure what the answer was, and I was looking at the wait times report from 2022, and certainly SBMC was pretty high. So in terms of Member Holmes's question, obtaining some of the NPR through utilization as opposed to rate increase would be beneficial, I think. And I guess I wanted to see what your position was on whether you would come before the board for a reduction if the utilization is higher than anticipated, because I think it makes it more palatable to accept the rate you requested.
Tom, I'll let you answer that.
Well, I think our position is there shouldn't be surprises, and we should come to the board based on if our volume goes up quite a bit more or if our volume goes down. I mean, I have to admit, I see the next 12 months as being very transitional, and every program we're talking about really doesn't come into place in 2024. It's more 2025 and 26. But you know, hypothetically, I think, you know, we're open to those type of discussions. But I think it has to be on both sides of the equation in terms of significant increases or significant decreases, and how we have to deal with that.
Great, understood. Thank you. I have no other questions.
Any questions from the healthcare advocate related to utilization or the conversation so far?
Hi, Director Lindberg. I just have one question, but before I do that, so Sam Peisch, Health Policy Analyst with the Office of the Healthcare Advocate. Just is the plan, Sarah, still to have questions that don't fit into these tabs come at the end?
Yep.
Okay, great. So my question, I'm not sure if this neatly fits in, but in the narrative on page 7, you noted that outpatient revenues combined with the medical group represents around 81% of net patient service revenue. And I'm wondering if the partnership that you talked about with Dartmouth, do you expect to grow that percentage at all?
Well, as I reported earlier, as we improve access and improve outpatient utilization, we will probably see outpatient revenues go up. But there's also a chance that inpatient revenues, as we start bringing people back and into the hospital, into the inpatient area, that may go up. So the percentages may, when you start using percentages, while the absolute dollar may go up, the percentages may fluctuate a little bit.
Got it.
I do believe that overall, we're getting to, we're at 81% on the outpatient side. It probably will ultimately long term, if I had a crystal ball, probably be between that 80 and 85%. But if we start getting some of those services that outmigrate to Albany and we keep them home, it may push that outpatient percentage down because inpatient utilization may go up, as Tom just talked about. But most of those increases in inpatient, I believe, are going to be in 25 and 26 as we get the services up and running and working more collaboratively with Dartmouth now that we're an affiliation of Dartmouth. So we got to be careful about percentages. Is my
Sure.
caution.
I agree. And you talked about becoming a regional referral center. I'm wondering if you expect, as that comes online, do you expect patients from states like Massachusetts to be referred? Like, is part of the goal to grow out-of-state patients, or is it more really reducing the outmigration within Vermont?
The first step is to improve the outmigration or decrease that outmigration. If we can get our tentacles out into New York State and bring back patients and improve our volumes, that will help the hospital. That will help Vermonters because it will reduce the cost of care in our facility because we'll be able to spread that cost over a wider base. Because part of one of our challenges is our size, and if we can get some more throughput, we can reduce the cost per episode. Go ahead, Tom.
Yeah, and just to add to what Steve said, Sam, I think you have to realize as we build services and programs, I think organically you're going to see more people traveling to our institution for care because the areas of New York, areas of the Berkshires, I mean, there's a good relationship in terms of people not wanting to travel down to Pittsfield or down to, Bay State Hospital for their care. They'd rather come somewhere closer by. So I think you'll see some of that happening. But clearly the biggest piece we're going to focus on is other Vermonters living in Vermont here, trying to have them stay close to home for care. And that's the huge amount of the $50 million I talked about earlier that's outmigrating.
Trey? Yeah.
Yeah, Sam, I just put some granular examples here. In the past, community hospitals haven't received patients often. They don't typically have a good process to receive a patient from a lower level of acuity, or frankly, from another community hospital. It just doesn't happen to have a service. So let me just give an example. Having 4 or 5 general surgeons at every community hospital is hard on each hospital. They may not quite have that business. But what happens is you have patients that present to NVRH or to Grace Cottage or to some other hospital, and they don't happen to have that surgeon on. So in the past, those would go to tertiary care centers, and that's just really not the best way for us to all collaborate and work together. So SVMC is trying to, like some other community hospitals, say, here's what we have. Here's the phone number to call. Let's make this easy. If you have a patient and you don't happen to have that service that day, or you don't ever have that service, and we do, let's take care of the patient here rather than in Albany or Bay State. That's where these patients go if they can't get into UVM or DHMC. Plus, there are call centers now with UVM and DHMC who are trying to do this by phone. They're trying to say, where can this patient go who happens to be at at Brattleboro or some hospital that just for some reason doesn't have that service this day. Let's do it in a coordinated way. And we believe SVMC has the size and capacity to be able to take on these patients and provide that service again, rather than transferring them out of state, which we have just seen is more expensive.
Got it. Thank you. That's all from us for now.
Wonderful. So in the interest of time, I think if you could just give us a high level kind of the cost inflation spread that you used for your budgetary purposes, and what proportion of that kind of is driven by the pharmaceutical growth.
So, we used in the budget 4 to 5%, depending on the commodity, depending on what we're seeing in some of the contracts. Now, some of the periodicals said you should probably use a higher number. Some of the periodicals said you probably should use a lower number. We feel that the 4 to 5% is a good range. We also historically have always tried to be a little tight on that to create thought process with our managers so they can find efficiencies and create. And, one of the things that I've used over the past 12 years at Southwestern, I've used it over 25 years, is a software product that is off the Medicare cost report and gives a lot of information. The Cleverly Associates, they calculate a cost index. And we've always strived to be better than 1.0 on their cost index, because below 1.0 on their cost index, that means you're efficient. So we also look at that, and we've tracked that now for all the years I've been at Southwestern, and we've made improvements each and every year. So using the philosophy of challenging our managers, not always putting full boat inflation into the budget has worked to create some efficiencies. But we got to always remember, safety, patient safety comes first. Employee safety comes first. They're 1A and 1AA. So we can't jeopardize that. But we got to, we create a lot of creative thought process with our managers. So overall, that's our philosophy, and that's what we put in the budget. As for the pharmaceuticals, we put there's a 6.4% increase in overall costs. 340B savings and a 4% price increase. Now this is one area where we believe, and we've had a lot of discussions collaboratively with the Dartmouth pharmacy team, that we'll be able to save some money, just not in 340B, but with purchasing other pharmaceuticals through some of the integration, and also looking at our formulary and looking at other types of, going from name brand to generic. And I know Trey has been actively involved with some of our physicians in our pharmacy department, and he can talk a little bit about that just in general terms, if you don't mind, Trey, on the differences between name brand drugs and non-name brand drugs.
Yeah, well, mostly some of the opportunity there is on the monoclonal antibodies, the infusions like the Remicade, and the cost that is paid for those medicines. It's very complicated, depends on the payer. And sometimes it's the generic, and sometimes there's a better deal with the with the name brand. But what we have found out is that there's a fourth category there, and it allows for Remicade that's unlabeled as Remicade, but is made in the same plant under the same conditions, and not generic, because it's made under the same conditions as the brand, that's much cheaper. And so that in itself is a significant cost savings. There's also opportunity, of course, similarly in oncology drugs, and that's probably the biggest opportunity. We won't be able to realize that this year. I think this is more of a nationwide approach, but also working with DHMC to figure out ways to get better prices on oncology drugs. I think everybody can agree on that particular aspect.
Wonderful. And how do these inflationary pressures translate to your budgeted charge increases and the realized commercial revenue off of those?
So, Sarah, what we do is, we put our assumptions together on the expenses, and we look at everything, and then we go back and we look at our revenue models, looking at inpatient, outpatient, all the services, and that's how we build it, and we build our target. This year we built a target, making it a transitional year from a year where we lost money to a 1% operating margin. And that's how we build it. We look at the governmental payers, we look at all the payers and all the things we're doing to improve revenues without putting it on the charge increase. And this year, we settled in on the charge increase that we requested. And we all, in the narrative, we talk about that we didn't increase all our charges by that amount. We're increasing approximately 70% because there are some charges that, and taking the physician practices, all of our payments are pretty much off of a fee schedule. So why increase? Our charges are already higher than that fee schedule. So there's no need to increase those charges anymore because there's a delta already. And the fee schedule is only going up, and why keep increasing the charges? So we look at the sensitivity of our charges. We look at, I download, again, from Cleverly Associates. I'm able to get charges off of publicly data, and we compare ourselves more than once a year to what people in Vermont are paying, what people in Massachusetts are paying, what people in New York are paying on the charge level. And we try to position our charges accordingly. And there are some things that, we every once in a while have to do onesie, twosie adjustments, but for every time we adjust one up, we bring one down when we find that we're high. And I think 3-4 years ago, we explained this at length in our budget presentation. So we're very sensitive to how we build our charge increase to commercial payers. And Tom also talked about earlier in his presentation, our community groups. Well, one of the things that we hear in the community groups, the cost of healthcare going up. Okay, and that's driven off, off of the commercial rate increase we get from the employers. So we hear that loud and clear. Did that answer your question, Sarah? That was a long-winded answer.
Yeah, no, I think that's good. And I do want to leave plenty of time for board questions related and HCA questions related to the inflationary assumptions and price increases. But before I open it up to them, just two things we're asking all PPS or one thing we're asking all PPS hospitals is if between when you built your budget and now, we know that the Medicare final inpatient rate did go up a smidge from 2.8 to 3.1. Can you help us understand how that affects your budget?
So it went up a smidge, to use your word, which is less than $150,000 on our budget. And however, we have another assumption in our budget related to the Medicaid rate increase, which did not get approved in the budget. So they kind of, from governmental payers' perspective, I see that as a push. I also see some risk possibly in the outpatient area because the final rule for outpatient starting in January has not been finalized yet. So, there's always the Medicare inpatient, the IPPS, which you just talked about, but we sit around this August timeframe, and that usually gets approved later on. And it's not always the same as the IPPS, the inpatient prospective payment increase. So I don't want to sound, it's almost a rounding error in our budget. But it's another risk, and maybe it's an opportunity. 150,000, but we have a risk for Medicaid of 100, I believe it's 140,000. So they kind of negate each other, and again, it's not a significant number, and You know,
But Steve-
I'm actually, go ahead.
Steve, just to jump in, and Sarah,
Yeah.
what is not a rounding error, and which has us greatly concerned, is the fact that we may lose our eligibility for 340B if we don't hit the dish numbers there. So that is and that's something that we did not budget for, and it's a $5 million impact. So that is one that we are losing sleep over, and it's still yet to be seen as to how that plays out for us.
Yeah. Yeah, understandable. All right. Well, in the interest of time, we want to turn to our public comment in about 10 minutes. I would say this is a good time for board and HCA to ask other questions that you would like to clear up, remembering that our decision will be to establish a net patient revenue number in the order for fiscal year 24, and to think about how that relates to the commercial price to get there. So board questions. Oh, I'm sure you've
I have
got
nothing else.
questions, AB. Okay.
I have nothing else.
I have one more, which is around just understanding the Medicaid redetermination assumptions. I think I saw in your submission that you are assuming some increase in bad debt related to the Medicaid redeterminations, which makes sense if people are shifting from Medicaid either to uninsured or commercial. Did you have any assumptions around commercial, sense if people do manage to shift from Medicaid to commercial, the reimbursement rate will significantly increase?
So Robin, we discussed with our, you know, we've been with our charity care, financial counselors, whatever we want to call them, staff, and we were talking about how do we, you know, account for this and how do we budget for this. And Susan, the person who has most contact with the patients, didn't believe that there would be a movement from Medicaid to commercial. She didn't think the people that she deals with and works with, she didn't get a sense that many of these patients would be moving that way. And I got to go with her. She interviews these people. She actually goes to their houses. And so she was not really, she said, Steve, a big chunk of these people may end up in my office for bad debt, you know, may end up bad debt, financial counseling, discounted services, but she didn't see a large percentage of those patients moving up to commercial. And the assistant director, Jennifer Helfrich, she had the same feeling. And she's my data guru. And she says she can't recall. Now, granted, during the pandemic and the health emergency, there was no incentive. But she says, I don't recall too many, even before that, that people went off of Medicaid and became commercial.
Is that,
you know,
sorry, Steve, is that because she thinks people just get lost in the paperwork? Because certainly if they're losing Medicaid because their income has increased, they should be eligible to potentially move into the exchange with a subsidy.
She said, if I recall her conversation, she says, you know, yeah, there's a couple, Robin, but she wouldn't, you know, their feedback to me was, don't do it, okay? And they're the line people. Don't put any more money into commercial because you think a lot of Medicaid people are going to move to commercial. You know what, Robin, there's going to be a couple, okay? There's going to be some, but I don't think it's a material amount based upon what they say. And I got to go with them. And
Thanks.
they've been right. They've been right more times than I can tell you in my career.
That's all for me.
Okay.
Sal, this is Tom Walsh. Maybe I missed it. Will you be covering the cost report tab?
Yep, we can look at that now. So Southwest is a larger small rural hospital. And their case mix index is 1.4, so between the 25th and 50th percentile. This, I suspect, is distorted by the corporate relationship. So I don't know how to interpret that without some more information, but 36% would be on the whisker there. As far as cash, from fiscal year 22, it was 11 million. They are moving some money around for that ED modernization project. Yeah.
Sarah, can I just interject on cash for operations? Keep in mind, as we outlined in our narrative, our days cash on hand and the cash that gets reported on the Medicare cost report is SVMC's cash. Okay. Right. The way we have our corporate structure set up, we have cash in the parent organizations. Our investments are in the parent organization. So we sit at about 100. Our goal was 190 days. It's probably not going to get there. So on using the cost report, I just want everybody to know that there's other cash available. And yes, we have a foundation that has cash and that is contributing to our ED modernization project. And of that $30 million for the ED modernization project, about more than half of it is coming from donor money. We have that, and I think that's in a couple of the other measurements. When you look at the total margin of the organization, you'll see that the money coming in for that construction project, the accounting rules say you got to transfer it in, and it ends up in the total margin. So just be aware of that, and that's all cash coming in from the foundation.
Yeah, all completely. Yeah, important caveats. Profitability for EBITDA per discharge right at the median. So that number for fiscal year 22 lower than people would ideally like to see. And this cost per discharge is quite striking at 8,000, which is below the 25th percentile. So that again is a cost calculated by cost center CCRs. So
and this data on the cost, I paid special attention to this and compared it to our Cleverly benchmarks, and it's consistent with what we've been using over the years.
That's great. Thank you, Sarah. And I just wanted to take a moment to have really a couple comments, right? This is, thank you for your presentation to us and what you've described as your community focus and your addition of primary care service lines and mental health focus and substance use disorder focus is really outstanding. And thank you so much for that. Similarly, the nursing team story was outstanding. And the cost per adjusted discharge data shown here is also outstanding. But I did want to ask about the ratio of administrative and general salaries, because that doesn't quite fit the picture of the rest of your organization. But this suggests that this proportion of salaries going toward administrative and general expenses is on the very high end compared to the money being spent on clinical care. And I was just hoping you'd help us try to understand.
Yeah, Tom, I have not been able to. I believe that's cost reporting techniques, and we can get back to you on that. I believe I was a little perplexed on that one as well, because we do spend more on the Cleverly information. We spend more on clinical. This is an opposite of of what I saw on Cleverly. So I think this is a work in process, and we can dive into that and get Sarah a response that she can forward to you, because I think this is just a cost report thing.
Right.
Because I know from all the other benchmarks I look at, that's not the case.
Yeah, it
There's
does.
one-
For your,
Go ahead, Tom.
for your organization, it's the piece that doesn't fit. All
Yeah.
right? It's just helping us with it would be great. And just one more bit of kudos. Your staffing decisions, right? What we see across socially responsible hospitals across the country faced with difficult times. They don't fill open positions, they reduce administration, they avoid cuts to service lines, all the things that you were describing earlier. And so just it's really been a pleasure hearing you, and I'm thankful you've started us off.
Thank you.
Other questions from the board that you want to have before we say goodbye for this year?
I just have two questions I'd love to ask. One is, in the capital expenditures, you have a $7 million IT infrastructure upgrade. Is that to switch to Epic to align with Dartmouth, or what is that?
So our $7 million is our capital budget for 2024. That's our routine. That's the total capital budget for the organization on routine capital. That does not include the emergency room, the completion of the emergency room project. And of that $2 million, upwards to $2 million will be spent on IT infrastructure. And I would classify that in two ways. Every year you have to, for cybersecurity and for just IT, we need to spend money. And the second piece of that is going to be to build our infrastructure to be able to receive and utilize Dartmouth Hitchcocks to move to Epic. But that's at least a 3-year journey. So just to repeat, the $7 million is our total capital budget, routine capital budget, which about $2 million is IT, and let's call it $1 million, $1.2 million will be for that infrastructure to move towards Dartmouth.
And do you have an estimated expense of that transition to Epic? That's what that's going to cost Southwest?
That the estimate that we had, the last estimate we had could be as high as $20 million. But part of our relationship with Dartmouth is that we'll find funding arrangements for that outside of the hospital.
Interesting. Great. The other question I have is a little bit more conceptual, which often when we look at hospital consolidations around the country, it increases costs of delivering care, increases insurance costs. You talked a lot about the decreases in costs through affiliation with Dartmouth. Other than IT upgrades, do you suspect an increase in costs, and how do you think you can manage avoiding that trap of so many other organizations?
Well, it comes down to, paying attention to details. As Tom spoke earlier, the Dartmouth model is a little different than some of the, I worked for two huge systems. One's a nationwide system, and one was a system in New Jersey before it came up to Vermont. And I can tell you that Dartmouth does not utilize the same models that those systems did increase costs to the member hospitals. And, there are tons of examples of how costs are increased, but I think Dartmouth is very cautious on not adding cost onto the smaller hospitals. And we are focused on, in our budget, we are focused on supply chain, reducing our supply chain cost by the ability for us to purchase under their, they buy 100,000 of a widget and we buy 1,000 of it. Well, now, at 101,000, we can get a better price. So we're focused on that. Cost of borrowing will be less. Fees around certain things that we do, we can reduce because there's more mass. And we're committed to making sure that, and I don't want to speak for Dartmouth management, but they're committed not to burden us with high administrative costs as other systems have done. And we're going to manage that. Tom, you want to say something?
Yeah, just, David, I think two things, as Steve touched upon it. I think Dartmouth has a true focus on not building corporate overhead. Actually, most of the systems Steve's talking about has very large corporate overhead, and also to reduce administrative costs is another area of a focus that Dartmouth is talking about, and we're talking about too. And the other thing is that in a lot of the system-wide managed care negotiations are centralized, and that is not the case. Each hospital negotiates separately. It's not centralized negotiations, and I think that's, when you start having a single signature on managed care contracts, that's where you can start seeing costs going up too. So that's not the philosophy that Dartmouth has in their system, and our integration was approved without having that in place. So that's another thing. So, and also the fact that we are 2 hours away, and so in a sense it's we have to be able to run our operations, and I think that's going to allow us to focus very closely on the costs that we incur locally here.
Well, thank you. Well, I wish the best of luck for all of us that continues, and we'll see it unfold.
All right, questions from the advocate.
Good morning, still barely. Mike Fisher, healthcare advocate. First off, I 100 caveats about the data we have so far about redeterminations. May and June numbers were not typical groups. July's numbers we don't even have yet, but they were greatly impacted by the flood. But we have, I just wanted to, in response to Member Lunge's question about movement of people to possibly to commercial, I guess I hope you're wrong, Steve.
Me too.
Because we have a sizable number of people who are losing, again, 100 caveats about the first couple of months, but 40% of those being reviewed. And remember, we're doing 200,000 through the year. So it's a lot of people who are moving off of Medicaid. And so I wanted to make that point first. Many of them may move back, and I shouldn't go down this rabbit hole, but I want to make that point. And then ask a question. I noticed that your bad debt, your uncompensated care generally has increased. 22, it was in the $7 million range, and projected for 24, it's in the $10 million range. Is the answer to that question the same answer you gave Robin about increased number of people of moving off of Medicaid to not being able to pay?
Correct. And the other, of course, price increase over the 2 years has a factor in that number. But we believe that number, I've looked historically, when we have our meetings on what the budget for bad debt and charity care with the staff that are on the front lines, we look at our historical trends, what we said, what we actually came in at. All but 2020, we were pretty much on target. So I'm pretty confident that we shouldn't go over, but the world's changing quickly with this redetermination, and it's a wild card. But part of the team's thought process was we are going to see that increase. A, it's in price, and B, it's in some volume, but not a lot.
Okay, your ratio of bad debt to free care is in the 3-to-1 range. And we've held out an aspirational goal of asking hospitals to attempt to achieve a 1-to-1 basis. You have a concept of what it would take to change that ratio?
Take, I kind of, and some people like this and some people don't, but there are patients that will cooperate and work with us, okay? And then there's patients that won't. So, improving and adding staff to go out and try to convince people, it's going to take some work. And right now, we don't see the return on our investment there. Because at the end of the day, the people that will work with us. And you can't force them. So the people who end up in charity care, I wish everybody from bad debt would work with us, because we can move them into charity care or some sliding scale, okay, as the as our policy calls for. But it's a difficult thing. I've been in the business, and as Sarah said, I'm sunsetting, I've been a CFO over 32 years, and I still haven't found the secret sauce to get everybody to work with us, and turn that number from the bad debt into charity care. Maybe maybe my secret sauce wasn't any good. I don't know, but we're working diligently to qualify as many people as who want to qualify, and I think that's the difference. There are people that if they cooperate, we usually can find them something. Sliding scale, Medicaid, we can get them into a program. But the ones that don't cooperate, that totally ignore us, that is the real frustrating part of it.
So I think I won't respond to what's going on in people's lives that lead them to not respond, or what impacts that has on their ability to get care. You've heard me say that 100 times, so I won't go down that road. But
we treat everybody, Mike.
But I will say, I think the question for me becomes, what is different? What is happening different at different hospitals to lead to different outcomes here? Some hospitals are landing at a better ratio, from our perspective, a better ratio of bad debt to free care. And so I'll persist in asking that question at other hospitals, but that's,
okay.
Yeah. And then my last question is, I think we may have asked this question in the past, and I don't know if you can help give us any insights to it. In your bad debt category, it would be good for us to have a better understanding of what to what extent those people are from the uninsured versus commercially insured versus Medicare, and unable to pay the.
So I think what you're asking, and we can dive down. You're looking for how much of it is true bad debt, true charity care, free care, then how much comes from patients that have a high deductible plan where they can't pay their deductible portion, and how much is coinsurance and deductibles. Is that what you're asking?
No, not exactly. I would call all of it true.
Okay, all of it. Yeah.
But I am particularly interested in at this moment in the amount of Medicare bad debt.
Okay.
That's an area where I think we have some public policy options that I think you and the hospitals and the healthcare advocates office will agree on. But it would help us to have some insight as to the amount of bad debt and free care that you have for people on Medicare.
Okay.
We can follow up later.
We can follow up later. Yeah. Yep.
Thank you. Thank you, board.
Thank you. I think this would be a good time to offer a chance for public comment. I don't remember what number I'm supposed to count to, 11, 20? Okay, so hearing none, we'll just give Southwest, if you could keep your remarks brief, sorry to go over time, but just any last comments you want to leave the board with before we let you off the hook for this year.
So Tom, before you make your final comments, can I make a final comment?
Sure.
I'd like to thank the Green Mountain Care Board. You know, as Sarah pointed out, I am retiring. And I'd like to especially thank Sarah for, you know, this, I'll call it this tool. I think the tool has been a help. We haven't totally dissected it, but, and I just want to thank the Green Mountain Care Board staff and the board members for the years. You know, sometimes it's been challenging, but it is, it's an evolution. And thank you, Sarah. Thank you, board. And keep this tool up, Sarah. I think it will be helpful. You need to tweak it a little bit, but thank you, everybody.
Thank you, Steve, for your service.
And actually, Steve stole my closing comments. I wanted to thank him officially too. I think he's done a tremendous job, and thank the board. This is a tough year for all of us, and we're entering into some uncharted waters with our new relationship. But our commitment is to continue to focus on our mission, our community, and we'll certainly be as transparent as you know as possible, and certainly try to reduce surprises and make ourselves available to sit down at any point in time to talk to the board and to update you on where we are and what the concerns are and what the future direction is. So thank you for your time today.
All right, I think that concludes this hearing. I don't probably want to take it from here, Chair Foster.
Sure. Yeah, thank you all. And, you know, congratulations on the forthcoming retirement. And we appreciate the presentation. We'll take a break. We're going to take a full hour break. There's a couple things board members have to do in between. So we'll come back at 1:07 and have a good day.
Thank you.
Thank you.
Thank you.
All right, so I'm just gonna do a mic check again, or Cassidy, can you hear me okay?
Yes, thank you so much, Chairman.
Oh, great. Tom, you got your hand raised? Okay, it's 1:07, and it looks like we have all the board members and Mr. McCracken and Director Lindberg. So I'll turn it back to, I'll turn it to Brattleboro, I'm sorry, Mr. McCracken to swear in the witnesses, and then we'll get going.
Thank you, Chair Foster. For the Brattleboro team, who could you let us know who's going to be presenting and answering questions?
Hi, yes, thank you. Thank you. I'm Chris Stardy. I'm the president and CEO. Next to me is Jody Stack.
Sorry, we can't hear you if you're speaking.
Oh, I'm sorry. Is this better?
Russ, I can hear them.
Okay. So I'm Chris Stardy, the president and CEO. I'll be speaking today.
Jody Stack, Chief Operating Officer, Chief Nursing Officer.
Dr. Kat McGraw, Chief Medical Officer and Chief Medical Information Officer.
Rhonda Calhoun, Board Chair.
Jennifer Griffey, Chief Financial Officer.
Yes. Can you hear now, Mr. McCracken?
Can you now Zoom?
We can hear you now.
Can Mr. McCracken hear us?
Yeah, we can hear.
Oh, good.
Oh.
I can't see that far, so it's okay. I think that's right.
If it's no trouble, if Mr. Doherty, could you spell the names of each of those that you listed for me?
Sure, no problem. So Rhonda Calhoun, our board chair, is RHONDA CALHOUN. Jennifer Griffey, our chief financial officer, is JANNIFER GRIFFEY. Dr. Kat McGraw is actually Kathleen, KATHLEEN, McGraw, M, small c, capital G, RAW, and she's an MD. Jody Stack is our Chief Nursing and Chief Operating Officer, JODISTACK, and she's an RN. And I'm Chris Darty, CHRIS, DOUGHERTY.
Thank you.
You bet. Thank you.
Great. Thanks very much. If the Brattleboro team could raise their right hands, I'll swear you in. Do you solemnly swear that the evidence you shall give relative to the cause no other consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
Great, thanks very much. And I think the
you.
floor is yours.
All yours,
Well,
Rhonda.
good afternoon. As I said earlier, I'm Rhonda Calhoun. I'm chair of the board of directors of Brattleboro Memorial Hospital. And I'd like to thank you for your time and the opportunity to present our 2024 budget. We are proud to present this budget to you, for our entire board finds it reasonable, responsible, and most importantly, responsible to the needs of the community that we serve. Many of us are looking at COVID in a rearview mirror. However, healthcare is still recovering and faces continuing challenges. This budget has been thoroughly reviewed rigorously, and including our finance committee of the board working closely with staff to develop the budget, our entire board review, which is comprised of community leaders, And finally, a review with our legislative delegation so that we could obtain their feedback as well. All parties have found this budget to be reasonable and directed to quality care and sustainability in our future. Now, I would like to introduce a couple of other people that are here in the room. Our Controller, Laura Bruno, is here. Our Chief Information Officer, Steve Cummings, is here, as well as our Director of Development and Marketing, Gina Pattison. And I would also like to put the table back over to you, Chris. I think you have a brief opening statement.
I do, thank you. Well, we'd like to thank you, Chair Foster, and members of the Green Mountain Care Board for your time, your guidance, and your service. I'd also be very remiss, I understand, if I didn't thank Director Sarah Lindberg. I understand she's been sensational to work with throughout this process. And I'd actually like to give an enormous thank you to Rhonda for being our board chair and her great leadership. This is a very difficult time to chair a health system board, especially in Brattleboro, Vermont. We're about to celebrate our 120th anniversary of service to this community. In those 120 years, there's been a heightened sense of dependency, expectation of service, expectation for improvement, and expectations for us being responsive to the needs of our community. These have intensified over these 120 years, and Rhonda is in that glorious situation of getting to be here right now when they're probably at the highest they've ever been. Somehow, Rhonda and our board keep us focused on our high calling of making lives and health better for our entire community. Our board pushes us to serve our community with excellence, and they do so through a balanced scorecard approach. This approach actually tracks our progress on 7 key strategic priorities. Today, we'll probably hit on 3 of them that are key to our budget presentation, and they include elevating the health of the community, recruiting, retaining, and caring for our phenomenal team, and of course, exercising wise financial stewardship. Now, these 3 play a prominent role in the development of our reasonable, responsible budget that is responsive to our community's needs. I'd like to quickly highlight that our budget has a major uniqueness to it. I'm sure you're going to hear this 14 times, but this one really is unique. We are the only Medicare designated dependent hospital in the state of Vermont. In 1987, the U.S. Congress established this program to help support small rural hospitals for which Medicare patients make up a significant percentage of patient days or discharges. That's us. This was put in place because the federal government acknowledged that Medicare on average only pays about 84% of hospital actual inpatient costs. And I believe Director Lindberg actually has some graphics that support that. We actually get a somewhat more robust payment from Medicare since we have very limited opportunities to make up cost anywhere else. This program is in place through September 30th, 2024, and there is actually a bipartisan bill in the U.S. Senate that would make this designation permanent, and we are hoping that that comes through. This is all very important in helping us achieve our goal of being the enduring hub of hope, health, and healing for our entire community. We realize we cannot do this alone and that we must work in and with our community. So now we're going to ask Dr. Kat McGraw to talk about some of the work that we do with and in our community.
Thank you. So BMH is not just a hospital, though we are that. And we're not just an independent medical system, though we are that too, but also an integral part of the Brattleboro community. And we're dedicated to improving the health of our community. And we start doing that by providing the foundation of health, which is primary care. We have 5 practices with a total of 15 clinicians providing primary care services. Each of these is a level 3 patient-centered medical home, reflecting our commitment to ensuring excellent primary care that includes care coordination, access to services, and continuous improvements in each of these areas. And it's working. We hear it from our patients. Here's one recent example. Hi, my doctor called me at home and told me to get ready and have the ambulance come get me and get me to the hospital. And if he wouldn't have done that, I probably would have died. So I ain't got nothing but good things to say for saving my life, about my doctors, about my heart doctor. Thank you. We build on this work through collaborations to provide the right care delivered in the right location, keeping it as local as is appropriate, collaborating with Dartmouth, Cheshire, UVM, and community organizations to ensure this. For example, our Dartmouth and Cheshire collaborations ensure that we have board certified ED providers delivering high acuity care that our primary care cannot, and tele-ED coverage to help support unexpected surges in volume or acuity, because there really can't be anything unexpected in an ED, and we know that our community depends on this. We lift the health of our youngest community members with our birthing center. Last year, we delivered 273 babies in what would otherwise be a maternity desert. It is more than 60 miles to the nearest NICU nursery. So our tele-NICU collaboration ensures that babies who need NICU care can get it before their transfer has even begun. These are but a few of our essential clinical collaborations providing necessary care in an affordable and sustainable way. We are here every day, ready to treat whatever's presented. We're prepared to treat the persistent heartburn that might turn out to be a heart attack or gallstones or an esophageal rupture, or maybe just heartburn. It's what we are set up to do. Vermont is not well set up to deal with mental health crises right now. Mental health resources across the state are not sufficient, and the number of patients in crisis in our ED is increasing, and unfortunately, so is their length of stay. The ED is not a good place for these adults or children in crises who sometimes spend days or even weeks in our ED because there are no appropriate psychiatric beds available. We have invested in numerous unreimbursed services to assist in improving this, from constructing a calmer space to providing telepsych consults to hiring an ED-specific social worker. We have recently stepped even further into this space as leaders, creating HealthWorks ACT, a new program intended to be a replicable model for other Vermont communities. It brings a data-validated approach to mental health treatment with medical care, homeless services, and peer support on a 24/7 basis for adults with mental health diagnoses and housing instability. Our goal is to treat these patients before they need the ED or inpatient services. It costs less on a per person per month basis than 1 day in the ED or 1 day at the retreat. We know we're having an impact on the health of our community. We focus on creative solutions that address the issues in ways that are not just responsive, but preventative. And our budget for FY24 follows this philosophy. Jody?
I'm Jody Stack, Chief Operating Officer and Chief Nursing Officer. In order to serve the community in all of the ways Dr. McGraw mentioned, we need to recruit, develop, and care for the people who work here. We pride ourselves on providing many pathways to a career in healthcare and to removing the barriers to getting there. In less than 5 years, we've raised our minimum wage from $12 to $15 and eventually $17 an hour. We provide scholarships for certified medical assistants, licensed nursing assistants, LPNs, environmental services, and most recently, phlebotomy. We have on-the-job training programs for entry-level care providers, such as medical and patient care assistants. We offer significant financial support for professional development and higher education through scholarships, tuition reimbursement, and other professional programming. We host clinical rotations for nursing, pharmacy, and other technical programs. During the pandemic, we worked closely with our affiliated nursing schools, specifically Greenfield Community College and Vermont Technical College, to keep those programs running safely throughout. In 2019, we created a new RN graduate nurse residency to ensure a safe and rewarding transition to practice for new graduate RNs. Last month, kicked off the 2023 residency program with 9 nurse residents in our progressive care unit and emergency department. I wanted to share a reflection from one of our nurses who was the recipient of one of our VTC LPN scholarships. This year marks 10 years for me at BMH. I started working in our coffee shop and from there landed a position as a unit secretary and LNA. I gained experience over the years in many departments, including SCU, PCU, short stay, and MS2. My experience on MS2 sparked an interest in orthopedics, and after graduating from Vermont Tech 1 year ago, I decided to try the outpatient setting. Our department is very busy, and working here so far has been a new and exciting experience. When providing care, no matter how difficult the situation, I always ask myself, what if this was my family member? What can I do that will make this patient remember me in a positive way? I wanted to share this as just one small example of the difference it makes when we invest in the members of our community, both as employer and as a provider of healthcare.
Thank you. My name is Jennifer Griffey. I'm the Chief Financial Officer at Brattleboro Memorial Hospital. I just wanted to start with giving you a landscape of where we started at the end of fiscal year 22, which was from a very fragile financial position. Brattleboro was hit strongly with the Omicron variant of COVID, taking out approximately 10% of our staff being unable to work, causing us to reduce our patient services, including the closing of our ORs. We ended up in fiscal year 2022 with approximately $4 million operating loss. Fortunately, fiscal year 23 has proven to be a different story. This has been a story of a turnaround for us. Services have stabilized as a result of the lost services and closed services from Omicron, including the opening up of all of our ORs. We're seeing a trend of a $736,000 loss as of our June financial statement closing. And while that may be a loss, that represents approximately a $3 million turnaround from fiscal year 22. We feel that we're on the right trajectory from a financial perspective. However, we do know that more work needs to be done from this fragile financial position, which is the reason why we approach this budget from a reasonable perspective, a responsible perspective, while keeping an eye on providing first-rate healthcare to the community of Brattleboro. To walk you through a little bit of how we approach this budget, and I know Director Lindberg will get more into the details, but I do want to set the stage. We do have a reliance on the IPPS increase for Medicare. If we remember what Mr. Doherty talked about, we are a Medicare dependent hospital, meaning that the majority of our patients are Medicare or Medicare Advantage. We needed to rely on that increase. As a result of Medicare not supporting all of our operating expenses, we are reliant upon the Medicare dependent hospital status, which provides an enhanced reimbursement to support that shortfall. We do have a small utilization increase of 1.6% for next year, fiscal year 24, which results in a very, very small and modest commercial rate increase of 1.5%. We approached our expenses from a very responsible and fiscally conservative manner. We asked each one of our directors to approach us with a 1% challenge. Can we do 1% better on finding more creative and fiscally responsible ways to our administrative costs? We intend to rely less on contract labor, filling our open vacancies. We also have participated in yellow belt lean training for every one of our managers and directors. So next year we can focus on finding and implementing workflow optimization, causing us to have less reliance on administrative costs. We're looking at using augmented intelligence to automate manual tasks, thereby reducing the need for FTEs for these manual tasks on the administrative side. We are also anticipating less use of energy and becoming more fuel efficient with the replacement of our boilers and plant services with the Ron Reed Pavilion that was open this year. All of that results in a very, very modest gain of 0.7% on the operating margin, or $845,000. All of this we need to support continued support of our community. We need to ensure compliance with our debt covenants. We need to replace end-of-life patient equipment, our IT infrastructure, and of course, maintaining our facilities. We also keep an eye on our investment to the community. My esteemed colleagues have addressed some of the things that we do as a health system to support our community, including supporting a labor and delivery, allowing Vermonters to be able to deliver their children in their home state of Vermont. With that, Chris, do you have anything else before we kick it over to Director Lindberg?
Thanks, Jennifer. No, it's all yours. That's our opening. Thank you for the time.
Sarah, you're maybe muted.
I think. Can you hear me now?
Yes.
Yes.
All right. Double mute. Practice. Okay. So when we look at Brattleboro compared to other prospective payment hospitals, we see that their NPR growth is among the highest. We also know from their opening remarks that this is almost entirely Medicare-based reimbursements and utilization. We do see on the expense growth side, operating expense growth from fiscal year 22 of under 9%, just under 9%. So that is very close to what we're looking for on a benchmark for expense growth. So that is where they stand in relation to their peers. And so that 19.9 we said is all NPR, all payers, all the time. So the commercial price, if we go back, I'm sorry for a moment, is estimated to net 1.1% from fiscal year 23 to 24, based on 1.5 on the charge master. So very small increases from 23 to 24 for price. As far as operating expenses, again, we don't have that benchmark, but very close to what we were hoping to see for revenue growth. And then the labor expenses, so these are per FTE rates. What we would expect to see based on the employment cost index is a range between 0.8% and 9.7, so very close to that. And when we look at that, we see the impact of those inflationary pressures to increase salaries between fiscal year 21 and 22, and seeing the decline in FTEs, which I assume is part of why the reliance on traveling nurses and locums has been necessary. But I'd be interested to hear kind of how you approach the labor challenges in your budget and what adjustments, if any, to positions you were considering as you built this budget.
Jody, would you like to start with that on the nursing side?
Right. So are you referring to the programs to fill the FTEs? So right now we have about 18 contract temps. Most of those are in nursing. I think 13 of those are in nursing. So those new graduate RNs by first quarter should be filling the majority of those nursing holes. We still are recruiting for experienced nurses into open positions, and we're finding people who left at about the 2021 mark for clinical positions are returning to the workforce. And so as we fill those throughout the summer and early fall, the hope is that by the end of calendar year 2023, we'll have most of those filled.
Sarah, also from the financial side of it, we had a $3 million budget last year for contract labor. We ended up reducing the contract labor to $1 million on the financial statements, moving the difference into salary, wages, and benefits, as we're seeing the less reduction on the contract labor, filling those vacancies as Jody talked about. So just wanted to point that out there when you see the increase year over year.
And just a practical thing as well, Sarah, while we did not implement a hiring freeze this year, we actually have implemented a more structured position control system that looks at vacancies, and we've had a lot of attrition. And with that attrition, a lot of those positions have not been filled nor budgeted for the coming year.
Thank you. And in terms of like the rate for contracted labor, what are the assumptions for fiscal year 24 as compared to 23? Level, up, down? What's your best guess?
We used level from fiscal year 22 to fiscal year 23. There's still some volatility on the rates, although I am happy to say over the last few months, we are seeing those rates actually go down incrementally.
Every little bit counts, right? And so
I'm sorry to interrupt.
and
Was
then
that Miss Jennifer Griffey speaking just now? I think you're off camera, so I'm having a hard time seeing you.
It is Jennifer. Yes.
Thank you.
Wonderful. So those were the main questions that staff had related to labor. Do board members have any questions on this area?
Hi, this is Dave Merman, and I must just say hi to Kat McGraw. We worked together 11 or 12 years ago in Greenfield and haven't seen each other since. So nice to see you, and I've been hearing your name since then. So the one question I have is actually on the report one. The physician fees and salaries are not in the FY24 submitted budget, but they were in the FY23 budget. And I was just wondering if that was an error in this submission form in this way, or if there's been a change.
There's been no change. The contract physicians are budgeted at their, sorry, I have to stop for a second. What was the answer to that? We have the answer.
The in-house people who work for the hospital.
Okay.
In the hospital.
So when we look at one, we put it in the hospital budget. They were all budgeted in-house. We can provide more clarification and more detailed if that would help the board.
That would be great. Thanks.
Just noting the follow-up here.
While you're doing
Okay,
that, Sarah, I'll just jump in really quickly. It sounds like, so prior to the pandemic, BMH had some very robust programs for growing your own, as people sometimes call it. And it sounds like those are coming back online and getting rejuvenated. So that was good to hear. I just wanted to confirm that my understanding is right.
Yes, absolutely.
Great, thank you. That's all I had on labor.
All right, any questions from the advocate on this topic?
No, thank you.
Wonderful. So turning our attention to utilization. So I think you're not the only ones, but the Exhibit 10 was a real bear for folks. It was designed to be simpler, but I think I made it more difficult. So just back of the envelope, can you help me understand from fiscal year 22 to 24, kind of how much of your budget is being driven by utilization? I think you said it in your opening remarks, but I wasn't fast enough to write it down.
No worries. So as I mentioned in the opening remarks, fiscal year 22, because of the Omicron variant and our staff needed to stay home as a result of that, we ended up closing our ORs, which is our largest service line. So there was a significant decrease in our utilization in fiscal year 22. We are seeing a bounce back. When we look at our overall net patient revenue increase, 17.24% of that is driven by the change between 22 and 23. 23, of course, as I mentioned in the opening statements, we have been able to reopen and stabilize all of our services, including the reopening of the OR. So that was strictly driven by the utilization.
Thank you. That tracks. And then the other notable utilization trend, and perhaps you can speak to some of the local challenges that might be behind some of this, but the significant increase in emergency department utilization. Just curious what's driving that, how you're looking at that, if any of that, how you think about that in terms of potentially avoidable utilization, and just trying to wrap our minds around that significant trend.
I can start, and if anybody else here wants to add anything, I'll start by saying that we have seen some increases. We know mental health is a part of that. As I mentioned, the length of stay is growing there, and we have put some additional physician hours in the emergency department to really assist with that, to turn around, the smaller problems more quickly. We've also started staffing one of our primary care clinics with a acute care option, so that folks can come in for any of those kinds of things that aren't necessarily emergency level and get in and seen the same day. So we're not entirely sure of what's driving it specifically, but we're putting in place things to help kind of decant it, as it were.
The only thing this is Jody, the only thing I would add to that is there's a lot of work being done, not necessarily on the specific to avoidable ED visits, but with multiple ED visits. So doing an analysis, people who are going back frequently and making sure they have outreach from primary care, that they have primary care first, that they have outreach, and if necessary, they have a multidisciplinary care plan in place.
Wonderful. And I don't know how closely you had a chance to look at these, but we see, and you mentioned in your narrative that a substantial amount of business comes across straight lines into Vermont for you all. And I was just wondering if kind of the magnitude and the share for your in-migration looked like you would expect for the facility claims. And similarly, you're not the only hospital in your HSA by far, but if these kind of out-migration dollars seem in line with what you would expect, or if you're scratching your head, just a kind of basic data quality check.
Yeah. So when we look at first of all, we are a border state. We border with Massachusetts and New Hampshire, and we have this year been looking at, from a commercial revenue perspective of what's being driven from that out of state. I can share with you of our gross revenue for fiscal year 23, approximately 21 to 22% of our gross revenue is derived from Massachusetts and New Hampshire. So it is an interesting landscape when you look at the outward migration. They'll come in for services and they need to go out to other places like Cheshire or Bay State down in Massachusetts. Does that answer your question, Director Lindberg?
Absolutely. And would you say that you noticed any differences in the rate changes between the in-state and out-of-state payers? Are they pretty comparable, or are they different?
That's a really, really good question. We haven't dove into that level of detail with the out-of-state payers compared to the in-state payers.
Okay. And okay, yeah, I think that would be really interesting. And I think as the board thinks about building its data model, we might think about ways to capture that in as administratively unburdensome way as possible. So those are my utilization questions. What questions do the board have related to utilization?
I'm so sorry to interrupt again. Can I just verify who that was just speaking before Miss Sarah? I'm losing y'all's visual every once in a while.
My apologies. That was Jennifer Griffey. I'll try and make sure I introduce myself next time. My apologies.
Thank you so much. And here in the cream shirt in the middle, what's your name?
Dr. McGraw.
Oh, gotcha. Thank you. Thank you.
Board questions related to utilization for Brattleboro Memorial Hospital?
This is Dave Verman. I could jump in on a quick question just to try to further dig down into the ED utilization. I think it was like a 14% increase from 22 to 23 and a 5% budget increase from 23 to 24. And Kat, you mentioned the increase of of having an available clinician at a primary care clinic. Do you have any idea of what that volume is annualized? If how that's going to affect ED volume, or if you think it's affecting ED volume, and if there's any other discussion of trying to expand more cost-effective care options for patients.
Yeah, I think that we look forward to it being very helpful, but it is an initiative that we just started. We have some clinicians who are providing those services. Really, it's only been a couple of months that it's really been rolling. So I don't think we have enough information to annualize it out yet, but clearly it's the right thing to do, and we'll direct the usage in positive ways, but the way that we're aiming.
And do you know if any of that availability is, I'm going to do my air quotes, off hours, other than Monday through Friday, 9 to 5 time frame?
At the moment, it's not, but we are, we're open to considering, a lot of different options that allow us to, in essence, decant that ED volume. We have also been tracking our next available appointments to be able to ensure that folks can get into any of their primary care appointments and don't necessarily have to utilize those acute care appointments if they don't need it to be done that way.
Okay. The other utilization related question I had, actually Sarah shed light on a few of them, which was in Exhibit 10, but on the out-of-state patients, do you have any idea of the payer mix of people that are coming across the border to seek care at Brattleboro?
The majority of the 21% that I had indicated a few minutes ago, over 14% is commercial. Okay. So as we come through the border, Medicaid, the states want the Medicaid to stay in their own states. a few of them Medicare, but the majority is going to be commercial payers coming over from over the state bounds.
Okay, thank you.
And I think you addressed some of these, again, faster than I could write in your opening statements. But the only other question that I wanted to make sure that we asked was just, you know, as you are onboarding folks and expanding folks, how do you fold that into your utilization assumptions? Like, do you expect kind of a exponential growth for them to get onboarded, or is it a more gradual kind of experience?
I'm not understanding the question.
Oh yeah, so I'm sorry. As you're still talking about adding some providers, the homegrown, if you will, does that affect your utilization assumptions, or doesn't matter who is actually providing the services?
Homegrown is.
So when you say homegrown, are you talking about nursing?
No, provider.
Yeah. So contracted versus salaried utilization, does that affect your budgeting at all?
No, because those are filling budgeted positions. So it's an either or.
Okay, and so the productivity expectations are equal,
right,
no matter. Okay. Just,
right.
Just curious about that.
Yeah, those are nurses, not physicians or nurse practitioners. So it's sort of a one-to-one FTE. We're not adding volume with that.
Yeah. Okay. Thank you. And sorry to jump back in. Any other board or advocate questions related to utilization?
I just have one. Thank you so much so far. I think in order for us to understand access issues across the state, but also to really put some of the utilization assumptions into some context, it's really helpful to know the referral times and the referral lags and visit lags, wait time information. And we had requested it by practice and by specialty area. But BMH submitted a very just summary measure across all their practice all your practice areas. And I'm wondering if you might be willing to break it down and resubmit the wait times information by practice specialty area.
Yeah, I don't have it with today, but we can certainly submit that. We've made some good progress with primary care, and specialties is varied, so we can send those.
That'd be wonderful. Thank you so much.
Yep.
Okay, and I think I neglected to ask sooner, but what sort of ACO participation are you expecting to do for fiscal year 24?
Again, we intend to participate in OneCare on the Medicare, Medicaid side.
Okay, sorry if I missed that. Just a lot of moving pieces today. All right, advocate, any questions related to utilization?
We don't have any questions. Thank you.
Okay, wonderful. So I think really appreciate that your cost inflation assumptions are within the benchmark. I was wondering if you could give us a little bit more understanding of kind of how those numbers break out for different categories. So for instance, you know, what's fuel versus drugs versus medical supplies? Just wondering kind of the range that gets you to that 6% overall.
Right. So on average, it's about 5% across the board. We are seeing a little bit of an upward trend of 8%. We factored in for supplies themselves as we see year over year growth on the supply cost inflation. But when we look at salaries, when we look at benefits, when we look at drugs, 5%, and then most of the other are contract services, with the exception of labor. They're 3 or 4 year contracts where they're pretty flat year over year with the actual cost assumptions.
So probably have more dramatic jumps in between those 3 to 4 year periods. That makes sense. And I think you addressed that question. The other question I had was related to, I think we talked about this quite a bit this morning, but as people kind of are unwinding from Medicaid to QHPs or potentially losing coverage, just curious how you approach those assumptions in your budgeting.
Right. Thank you for that question. It was difficult to put a good number with the Medicaid unwind for the last 2 years. during the pandemic, there hasn't been any redetermination issues, obviously. So we just didn't have a good data source for that. Anecdotally speaking to our director of patient financial services, what we've seen over the last couple of months are those that are unwinding from Medicaid are really coming more into a self-pay and charity or bad debt perspective. So we are optimistic that we'll be able to not have as a dramatic impact on the Medicaid unwind, but we do anticipate it going more to a charity care or bad debt.
Okay, and I'm sure you've got reasons why you made those assumptions. Can you share some of those with us?
Again, you know, it was difficult to make those assumptions and not having a long data set. What we had just didn't seem to be reliable for future predictions of behavior. Again, anecdotally, what we find are those, as we try to re-up on the Medicaid, tend to come down into the charity and self-pay. It's again based strictly on anecdote. When you look at our overall budget, the net payer revenue to what we have for charity and bad debt, we did keep that about 2.6%, which is what we've been seeing on charity bad debt aggregated over the past 3 years.
Great, thank you. And you mentioned in your budget a few additional expenses that you took on related to security to address some staffing issues in your emergency department, as well as some unforeseen repairs. Just wondering kind of like what that did to your budget, to your best estimate for 24.
For the budget, we just pulled forward what we were actually realizing in fiscal year 23. Those unforeseen expenses were actually realized in fiscal year 23. So when we look at the actual expenditures to the budget, we ended up negative in some of those areas, specifically due to these unforeseen. So we just pulled these assumptions directly into the fiscal year 24 budget.
Okay, yeah, I didn't quite follow that in the narrative. Apologies. And then in terms of like, you'd mentioned quite a few initiatives in terms of avoidable costs. What are kind of maybe the top 3 to 5 initiatives that you're targeting to address in 24, and maybe speak to some of the risks that you feel about those?
Right. So when we look at some of those initiatives, one of the big ones, and I'll turn it over to my colleagues in a second, but from the administrative side, we were really looking at how can we take some of the tasks, and I'll give you an example of cash postings, where we have an FTE doing those cash postings. Are they really working to the highest level of their skill set? Where we can automate some of those, look for opportunities to automate through augmented intelligence to automate those tasks, allowing the FTEs that we have to actually work to their highest level. We did have one FTE that was open for fiscal year 23 in our patient financial services because of this anticipated cost savings measure in fiscal year 24. We did not budget for that open vacancy. We ended up reducing it through attrition.
I think a couple of other things, Sarah, that we're working on, and actually one of them is in the room with us. We've created a shared service agreement with the Brattleboro retreat, which is about 1.6 miles away from us. And we actually share a chief information officer right now, something that neither of us could probably afford on our own, but we've gone out and done that. We're looking at other opportunities. We're working with Springfield Hospital, potentially sharing our cardiology program with them and finding ways to reduce costs that way. We also believe that care transformation is the best way to ultimately reduce costs. Talk about your avoidable emergency room visits, et cetera. Most states have been able to utilize community paramedics to actually make a big difference in these types of costs that are avoidable. We are about to do a demonstration project with Rescue Inc. in the state. It will be specific to our joint replacement surgeries. This will help us get to a same-day ambulatory surgery for all joint replacement surgeries. We'll do it in a safe way, and we'll do it in a high-quality way. But this is just to break the ice in the state of Vermont, which does not allow for paramedics to go into homes unless it's an emergency situation. Again, New Hampshire, Massachusetts, Connecticut are having great success with mobile integrated health community paramedicine. We're investing in this to break the ice so that we can start to do this. For us, we're paid on a global payment for these total joint replacements. So we'll be reducing our costs. Ultimately, we'll be able to demonstrate to insurance companies that we're going to be able to reduce their overall cost.
I would also add that, as I mentioned in my earlier remarks, HealthWorks ACT, which is our innovative project in conjunction with the Brattleboro Retreat, Groundworks, which is our local homeless services organization, as well as HCRS, which is our designated agency. That particular project is designed to really alleviate some of the need for folks to end up in our EDs and using those resources, which isn't the right place for them anyway when they're in psychiatric crisis. That is intended not just to be a program for here, but we're working very carefully in that program to ensure that it can be a model for replication elsewhere. So that's really getting ahead of the curve in that way. And then I would just finally add, unless somebody else has something else they want to jump in, but we have put a real increase in our emphasis on quality, which we have not spent a lot of time talking about today. But over the past couple of years, we have had a really significant increased focus on that. And as part of that, we've been working on getting lean training for folks here in the organization. So our leadership is getting yellow belt trained. Many of them are already at this point. And we have been doing that not just with the clinical folks, but with administrative side of the house as well, so that we can look for ways to streamline things on the clinical side, the workflows, but also within the administrative side and the workflows that are part of that as well.
Thank you very much. We'll just take a moment here, and we are, again, here to learn about the limitations and strengths of these data sources. So for your peer group, you're with other small rural hospitals, and Brattleboro actually is a very small rural hospital. You know, it's closer to a size that we might expect for a critical access hospital, which again echoes back to that Medicare dependent designation. And we see according to calendar year 22, we see a case mix index a bit above the median. So again, this line would be the 50th percentile. So we see that within the range of between 50 and 75th, but a bit higher acuity than some of your peers. We see a lower ratio within the 25th to 75th percentile compared to the other two Vermont hospitals in this bucket. For that, again, this is going to be the spending on basically line 5, I think it is, on the cost report compared to the salaries associated with lines 30 through, I think it's 110 or 20. So see that in the lower range than the other Vermont hospitals. And then for cash on hand, again, knowing that this is going to include donor restricted funds and other good stuff, see you 36 million. I think a lot of people's cash position in fiscal year 22 has changed. So not hanging my hat on this number, but relatively speaking, it was at the 75th percentile compared to other hospitals in this peer group. And as far as profitability goes, that's a tough number to see. Always not fun to see a negative number, but obviously you can see that that has been a real struggle when we look at the EBITDA per adjusted discharge for you all. So that it would be below the 25th percentile. So those are some tough operating results. And then when we look at the cost per adjusted discharge, you're just above the median at $10,000 per adjusted discharge. So what do you think we're missing in this look, or do you have any kind of concerns about the way that we've summarized the cost report, or kind of local conditions that we maybe haven't factored in looking at this?
I think from the cost report perspective, this was nicely summarized. I have to be honest, it was a little challenging for me to read with those little dots. So if we could blow that up for my old eyes, that would be fantastic next year. I do also want to point out on the cost or the earnings, the EBITDA per adjusted discharge, it is below, but as we said in our opening statement, fiscal year 22 was tough. It was a real tough year for us with close to a $4 million operating loss. So taking that into perspective.
Very, very important point. And when we look at the cost coverage, so we'll see overall, Brattleboro is, so again, would be the Medicare allowable cost at 58%, getting 58% of the allowable costs from Medicaid, 50% of the allowable costs from Medicare. Now that one makes me scratch my head a little bit because I would expect that to be a little bit more favorable. So I'm just curious if maybe some of the enhancements aren't flowing through claims, or if that number feels right to you. And then again, this is blended inpatient and outpatient, and then overall seeing 200% of the allowable costs from the commercial book in total. So also see, I was very surprised to see the outpatient cost coverage from Medicare being as low as it was, and again, seeing a common trend in that kind of erosion of cost coverage from Vermont Medicaid. So just anything you want to comment on, or ways
So Sarah, for Medicare, the Medicare dependent hospitals do not get the OPPS bump. And so we do have a disadvantage, quite candidly. They cut professional fee rates last year, bumped up OPPS. We did not get a bump in OPPS as a Medicare dependent hospital. It's being fought out vehemently. They do it for sole community hospitals, but they have not done it for Medicare dependent hospitals. So we're always at risk there that we actually typically take a cut in OPPS each year.
Thank you so much. That's why these conversations are so important. I absolutely see that differential between inpatient and outpatient that you mentioned here. So that's helpful context. And then finally, related to these standardized prices. So let me actually, for whatever reason, I can't get these to pop as much as I'd like. So we see quite low at the 25th percentile at 16,000 per price per inpatient stay. So this would again be the commercial payments, and we see that kind of flip towards the 75th percentile for outpatient rates. So I don't know if you feel like you're getting relatively better reimbursement on the outpatient versus inpatient side on commercial side, bearing in mind that this is data from 2018 to 2020.
That's a good question, Director. Again, because it was data between 2018 and 2020, in full disclosure, I didn't dive that deeply into it. It's 2 years prior to the pandemic. The entire financial world of hospitals really were turned upside down from fiscal year 22 forward. But if you'd like us to dive into it, we would be more than happy to and provide a response.
Yeah, I think I want to make sure that we're measuring the signal and not noise as much as we can. So not something that you need to spend a ton of time on, but just, a sniff test I think would be really helpful. And so, all that is translating again to a commercial ask, if you will, of, a little over 1%. So it just shows your reliance on Medicare specifically as a payer, I think. So with that, staff are done. Curious what questions board members have at this juncture.
I will jump in. I'm wondering, you had mentioned in your narrative that you are having some impacts from the Medicare Advantage changes that you're seeing. I wonder if you could elaborate a little bit more on that.
Sure. From a financial perspective, Medicare Advantage, we are seeing a shift from traditional Medicare into Medicare Advantage. The challenge we've been having with Medicare Advantage on the financial side are increased denials. It's causing additional administrative burden. We've actually shifted from 1 FTE to almost 2 FTEs to manage the denials and the collections on the Medicare Advantage. Dr. McGraw, anything on the access side with Medicare Advantage that you're seeing?
I don't think so. No.
And most of those denials, again, prior authorizations that need to happen. It also feels, and this again is anecdotally, just those denials keep going up. I hear it's a trend across the country, but we are seeing that and experiencing that here at Brattleboro.
Thank you.
And just to add to that, Robin, an enormous increase in the percentage of Medicare Advantage compared to traditional Medicare as well. It's been as high as 67% growth.
And may I interject just to confirm that they would not necessarily respect the Medicare dependent pricing?
Well, we still get the Medicare dependent up for that. So we do get that because that's federally legislated. And since they're working for the federal government, they do have to, Director Lindbergh.
Okay,
But,
well, that's
but
better
just
news
let
than
me,
I expected.
it is an odd thing. The Medicare dependent up is not a perfect tool. We love it, but it's not a perfect tool. They're still working off a base year of 2012 of Medicare rates, and we get about a 75% to the inflationary factor payment for all the work we do with Medicare patients. So it's still not really coming close to covering our costs.
I think that bore out in the cost coverage information. Yeah.
Okay, thank you.
Could I
had a
piggyback?
follow-up.
Okay.
Go ahead, Dave. Go ahead, please.
All right, just a quick Medicare Advantage related question that anecdotally I've been hearing of patients being denied coverage for ambulance transfers if it's not deemed to be emergent, meaning being within 6 hours of presentation to the emergency department. That would be transfers, from Brattleboro Memorial to other hospitals. Is that something you guys have experienced there with your patients, or that you know about at all?
We're not hearing about it. That's terrible. Let me just say for the record, we're not hearing about it, but it's very concerning because we know that access to tertiary care beds, it can be very, very limited at times. And, we, over the past year or two, have had to really search excessive distances to find appropriate beds available for tertiary care for our patients. So not familiar with that particular phenomena, but that may be a harbinger of something much worse. Yeah.
Thanks.
I want to follow up on the question about the denials, the increased denials. What are you comparing that to? Just that the Medicare Advantage denials are increasing, or versus denials in other carriers or other types of coverage? And then second question to that is, can you give us a sense of scope of how much larger the percentage of denials are?
That's a really, really good question. We've been comparing it to the same time last year. What were our denials the same time last year? And we've been seeing a trend up. When we see the trend up, we start drilling down into the payer mix. And what we're finding is that payer mix